My name is Kellogg Parsons. I'm a professor of urology and team leader for urologic oncology at the UC San Diego Moores Comprehensive Cancer Center. I'm also vice chair of the National Comprehensive Cancer Network Prostate Cancer Early Detection Panel. And what I'd like to talk to you today about is current recommendations for prostate cancer genetic testing, the NCCN Prostate Cancer Early Detection Perspective. I have no relevant disclosures. Our goals for this talk are first, to review the NCCN guidelines process. Second, to provide a brief review of the NCCN guidelines as they pertain to prostate cancer early detection and prostate cancer genetic testing. And third, to identify potential and ongoing opportunities for improvement. It's important to note that in discussing these goals, we will be talking about men without a diagnosis of prostate cancer, that is, men who are coming into the office and determining their risk of prostate cancer and having discussions regarding early detection and screening with their providers. And second, within this context, that every discussion about prostate cancer early detection, including those discussions that are focused on gentlemen in the context of genetic screening, always proceed from an initial point of shared decision-making. That is to say, informed decision-making and informed dialogues that are undertaken between the patient and the provider. So first off, the NCCN guidelines for prostate cancer early detection. What is the process all about? Well, the NCCN guidelines encompass 30 different centers, all National Comprehensive Cancer Network comprehensive cancer centers. The guidelines are updated at least once annually. Changes from prior versions are noted, and they're integrated with the NCCN guidelines for localized prostate cancer. It's important to note that all of these guidelines are available free of charge online at the NCCN website. Well, what is the composition of the NCCN panel for early detection and screening? Well, we have a number of different individuals who are representing different fields of expertise. We have 30 members in total. Most of them are urologists. However, importantly, we also have representation of epidemiology and population sciences, internal medicine, and patient advocacy. That is, we have a patient advocate who is a member of the panel. The guidelines themselves are formed as algorithms that are intentionally designed to be easy to follow and to have very discrete points of decision making within the baseline evaluation and risk assessment process for patients who have decided to enter into informed discussions with their providers about prostate cancer screening. The genetic guidelines specifically occur during the baseline evaluation, and there are 2 points that are made with respect to the initial baseline evaluation and the history of physical examination. The first is the recommendation to obtain a family cancer history from the patient, and the second is to obtain specifically a history of family or personal history of high-risk germline mutations. So again, the family cancer history, and second, family or personal history of high-risk germline mutations at the initial baseline evaluation in gentlemen who have decided to enter into informed decision-making about prostate cancer screening. With respect to the family or personal history of high-risk germline mutations, at the bottom of the first page of the first algorithm, the footnote specifically refers to what are called DNA repair deficiency germline mutations, specifically BRCA1 or BRCA2 are the ones that have been identified for prostate cancer as being particular genes of interest with respect to assessing prostate cancer risk. So the baseline recommendations If there is a suspicion of there being a germline mutation, specifically for BRCA1 or 2, the baseline recommendations that the NCCN guidelines include is referral to a cancer genetics professional if known or suspected cancer susceptibility gene. Also, in addition to those gentlemen who have a known history of being BRCA1 or 2 carriers, consideration should be given to more intensive prostate screening in these gentlemen, beginning at age 40 years and annually. The second part of the algorithm after the initial evaluation is if a patient decides to undergo management of biopsy, or rather decides to undergo a prostate cancer biopsy. What I wanted to point out here is integration of these guidelines with the NCCN guidelines for prostate cancer. That is to say, if a patient, through the informed decision-making process, decides to undergo prostate cancer screening, and in the context of undergoing prostate cancer screening, then undergoes a prostate biopsy, and the biopsy results determine that the patient has cancer, we have automatically built in to the NCCN guidelines for early detection, we have built in a link to take viewers of the guidelines directly to the guidelines for prostate cancer. In addition to the algorithms themselves, there is a text version accompanying the NCCN guidelines, and the text version devotes a significant portion of the materials to explaining prostate cancer risk in genetic syndromes. It's important to note that the NCCN guidelines are based on a comprehensive literature review, and so that all of the relevant literature that has been identified regarding prostate cancer risk and genetic syndromes is incorporated in detailed explanations within the text. What does the text do? Well, in the broadest terms, what the text does is it summarizes the literature. It notes the various DNA repair gene mutations, for example, BRCA1 and 2, but also other gene repair mutations such as ATM. It also identifies and discusses Lynch syndrome risk. And it also provides an indirect link to the genetic familial high risk assessment NCCN guidelines, which are a separate set of NCCN guidelines focused primarily on ovarian and breast cancer. What are the opportunities for improvement that we've identified? Well, first off, there have been inconsistencies noted with other guidelines. For example, the genetic familial high risk assessment guidelines to which I just referred recommend that men with a known BRCA1 2 positive status begin prostate cancer screening at the age of 45 years, as opposed to the prostate cancer early detection guidelines, which note beginning at age 40 years. Now, recently, there was a conference in Philadelphia, a consensus conference at which it was decided that these inconsistencies would be addressed, and that uniformly there would be the same age guidelines moving forward, whether one is referring to the genetic familial high risk assessment or the prostate cancer early detection guidelines. Secondly, along the lines of the inconsistencies with other guidelines, there has been an effort recently to improve coordination with the other panels. I already identified a direct link from the early detection guidelines to the localized prostate cancer guidelines, and what we envision in the future is that there will be further a direct link from the NCCN early detection prostate cancer guidelines directly to the genetic familial high risk assessment guidelines. The third is that we are improving our systematic processes for integrating new data. This is an evolving field. It's a moving target. There are constantly new genetic risk mutations that are being identified, and we are improving our processes for updating the guidelines in a timely manner so as to incorporate the new data on the genetic risks as they come out. And then finally, I think acknowledgement needs to be paid to the challenges of primary care. And what I mean here is that the majority of patients who undergo early prostate cancer detection and screening are not being seen by urologists. They're being seen by primary care docs. They're being seen by family practitioners, internists, folks who have many other things to consider in the context of a primary care visit for an older patient who is considering prostate cancer screening, and the challenges of integrating this new material into the context of a primary care visit so that men who are at increased risk genetically of being diagnosed with prostate cancer are identified within the context of a primary care practice and are sent appropriately for additional evaluation with a urologist. Thank you very much for the opportunity to present the NCCN guidelines for recommendations of prostate cancer genetic testing.